Thanks, Amy. And we're going to steal a little bit of your lunchtime, if you don't mind, just a few minutes. Thanks very much. We're going to have a little discussion here about some of the main points that were presented by the speakers in a moment. We're going to go to Q&A around 11:45 or so, 11:50. So if you got that question queued up, that would be very helpful. You've met everyone on this panel thus far, save for Mary Richards. Mary, if you just briefly introduce yourself, and we'll come back to you in a few minutes with a question.
Thank you.
You're on.
This is on. So I'm Mary Richards. I am the executive director of a coalition of patient advocacy organizations called Partners for Better Care. We're a patient advocacy organization-led coalition with a couple of industry and payers that are in membership as well. So I'm delighted that I get to work with folks from AIDS United to United Cerebral Palsy on a regular basis, looking at issues related to quality health care that exists in America but is not always accessible to all of us with multiple chronic conditions and debilitating diseases. And we're trying to solve for some of these issues related to how it is that patient advocacy organizations and the folks that they represent can be at the table during these discussions related to all of the things that we've heard today and health system and payment reform efforts. We have all felt a notable absence from those types of groups as these conversations have unfolded over the last several years, and we're looking forward to being at the table in a more rigorous way in the future.
Good. Thank you very much, Mary. I want to go back to Veena on the literacy issue. And that was a great explanation for kind of where patients are and so forth, where the system is and who might benefit. Tell us a little bit more about what happens now between patients and their doctors from the standpoint of cost and financial toxicity. How is that conversation going, and how might the work that you are doing help better support that essential interaction? Talking about costs.
Yeah, I think that's a great question. And as there's been sort of this, I would say, increased awareness of the problem of financial hardship, there's been a lot of interest in from organizations like ASCO, American Society of Clinical Oncology, to improve communication between patients and physicians about the cost of care. But what that actually involves, I think, is a little bit more obscure. Do we talk about the specifics around how much a drug is going to cost or a service is going to cost? Do we talk about, or do we simply acknowledge that the cost of care is substantial and that we understand and we acknowledge and appreciate what the struggle that patients are going through? What exactly does that communication involve, and how do we incorporate that into the flow of clinical care? So I think those are some of the challenges, and I know a lot of folks are working on trying to address that interaction and improve that interaction. We've really, I would say as a clinician, I acknowledge the difficulty in being an expert on the cost of cancer care as well as an expert in the treatment of cancer. And so, and this is even from someone who thinks a lot about the cost of care issues. And so I think it's critical to really think about how, as a clinic and health system and programmatically, we can improve communication around the cost of care, including patient advocacy organizations and organizations within the community that do this every day, all the time. And also within our health systems, developing strategies to actually provide patients with information about what treatment is going to cost them before the fact.
But Veena, how, you're not the average clinician out there. How up to speed are most of America's doctors in parsing financial toxicity for diverse patients? Are they ready for that? Have they been trained for that? Can we ever get there?
I mean, I think there's really minimal training around this. I think that most clinicians are caring and they recognize if people are struggling. But a lot of that is dependent on patients actually bringing up the issue. I don't think that we're trained in asking questions around financial hardship.
So there's a gap there. Do you need decision support? I mean, it's a yawning gap. We want them to talk about this stuff. Patients want to trust their doctors, but most docs can't, it would seem, as you said, aren't ready to do it.
I think the first step is really acknowledging that there might be financial side effects of treatment and assembling a team around trying to address that. Because
Okay.
I think it's challenging for doctors alone to navigate that.
Got it. So, Andrea, we heard this morning from Melissa Thompson, who is not your average patient either. An MBA in Goldman Sachs, come on. And this is obviously a highly trained, highly educated, highly intelligent person who had a heck of a time negotiating this. What can your peer support angle help to support or promote insofar as these very difficult cost decisions?
And it's a very good point that she is not your average patient, obviously. I don't believe that I was an average patient when I was subjected to having to make those decisions. And so, when we're talking about what we can do, we have to remember that on our level of discussion, we are not the average people who are actually out there making these decisions. There are people who are having to make the decision of, do I take this medicine that costs even $15 a month, or do I buy food for my children? And so there's a very big reality in the gap of information, I believe, that people who are making programs and decisions, they're not really down in the trenches with the people. And that's where peer support comes in. When you get down there and you talk to the people and you're with them, sharing on their level, you hear what the problems are.
But are you able to kind of, when you bring your peer support and you had a wonderful slide of bullet points of things that you can kind of bring to the discussion, is one of those, listen, don't be afraid to talk about costs and maybe I can kind of help you start thinking about it? How do you sort of introduce that and kind of give them a boost, at least in the beginning, to approach that issue?
The first thing you have to do is empower the patient to feel like they're worthy of talking to their doctor. We were trained as we have grown up that your doctor is so smart and they're so intelligent, and anything the doctor tells you, you just need to do because that's what the doctor says. And so to empower that patient to say, look, I realize that this is what you believe is my best treatment option, but theoretically, I can't, just financially, I can't do this. Is there a different way? And to be able to open those conversations with your doctor, I think has to come from empowering the patient in the first place to feel like they have the right and the ability to challenge what the doctor is saying.
Do patients want to actually ask the doctor? Patient, as you pointed out so well, and Melissa underlined, you're in the most vulnerable position, most vulnerable time of your life, and all these things are spinning around your head. It almost seems like a challenge to the physician to say, well, how much is this going to cost? Because some of that cost is going to be physician cost, right? Isn't there sort of a little bit of, not intimidation, but trepidation to raise this, yes?
Absolutely. And also, who wants to be the person, like, I didn't want to be the mom to be like, look, my son's life isn't worth this $7 million that you're asking for. I mean, who wants to put a value on a life and say, that's not worth it to me? It's obviously worth it. I would pay whatever I had to. But in the real world, if you don't have it to pay, you don't have it. It doesn't matter.
Not even there, right. Mary, your organization really spans multiple other organizations in many disease areas. Are there any kind of take-home lessons about how your organizations are doing sort of maybe best practices in broaching this topic of financial toxicity?
So I think there's an overarching experience across the different disease states, which is you take somebody who is either receiving their own complicated and highly emotional healthcare diagnosis, or one of a child or a parent or loved one, and then we put them into one of the most complicated financial instruments that we have, right? So then we dump them into the coverage world, which is both highly critical but also really complicated. And just last year at this same event that the Pan Foundation hosted, somebody from the American Cancer Society was explaining how they have a whole other layer of training now with their call center folks who have historically been sort of best in the business, best in practice in terms of their call center expertise to help people navigate the complications around coverage and care options in a multitude of the hugely diverse world of cancers. and that they were having trouble just understanding some of the mechanisms that existed in the new insurance models, right?
Uh-huh.
So here we are looking at multiple different chronic conditions, many people living with multiple conditions at the same time, and one of the things that our groups are doing is trying to develop qualitative data to explain patient experience in a way that then can inform things like what these researchers are looking at. So whether it's peer support programs, financial literacy programs, there's an increased interest too in not only having financial literacy programs for patients, but also the specialists that treat them. And it's unexpected that a doctor would be able to tell you, with all of the options in the healthcare marketplace, that they would be able to navigate what your plan is going to cover in the moment that you're talking about.
So who's going to do that then?
So we have peer support programs that are being launched right now. Those are really helpful in many ways. The call centers are also another way of dealing with these questions that come up. Again, there's a emotional pressure in the moment of a diagnosis, and you can't possibly ask all the questions in that moment. So how is the follow-up going to occur? Those call centers do facilitate that. We also have a number of groups that are doing very specific case management and casework. So AIDS United has a program where you literally have a caseworker who walks you through both the healthcare diagnosis as well as the financial elements of it, and then they connect you with things like patient support programs, other grants that are out there, housing issues. There's a multitude of issues. And then I also think that there's a group we work with called the Hemophilia Foundation of America that's just actually right now trying to ask the right questions of their population so that they can then develop the support programs that are needed.
So here's something that's very troubling to me, having heard what we discussed this morning. Before November 8th or January 20th, it was already pretty complicated.
Yeah.
And all the experience the research that's been done and the experience that you shared with us was really tough then. Aren't things a little bit more uncertain now? And we weren't doing it so well then with managing kind of the financial challenges. And now it seems to be far less certain and more risky. Who's going to be ready to start to be able to kind of adapt on the fly here to answer questions when it sounds like the financial burden net may even be higher if the ACA kind of recedes somewhat? I'm sure that was a trivial question. Jalpa, do you have a thought on that? She's so smart, you know, Miss Research. I also went to Penn too, but I wasn't as smart as you are. I figured you have an answer to this.
I wish I had the answer to this. I think, firstly, there's just so much uncertainty about what's going to happen.
Can you model this stuff? You're a great modeler.
I think it's only going to look worse than what we've already shown you in the figures. And,
Do you hear that?
And I think, but there's just so much uncertainty, as Tricia was mentioning earlier this morning. Like, you know, we don't have a crystal ball here, and we've also heard a lot of different stories around what is going to be proposed or what might happen. But clearly, if the ACA is repealed, we'll have a lot of patients under health insurance exchanges, the Medicare expansion, plus the, what Tricia was referring to again in the morning about the specific elements in the ACA that are actually protective for these Medicare beneficiaries, like closing off the donut hole. Like, we don't know what's going to happen next. Mm-hmm. And I think, but the big story right now is for us to just think about that given where we are at, it's a huge issue to begin with. Yeah. And to me, what's been really interesting is to hear all the panelists this morning talk about different strategies. Kai talked about a value-based formulary. So we have one stakeholder in the system where an employer-sponsored plan has decided to implement something that we've been talking about. Mark, how long have you been talking about value-based insurance design now? I've been here when I started. There you go. And now we have just one insurer that has a model formulary for that. I mean, how many plans do we have in the United States?
Well, here's what got me. The reason I asked you this question is that your solution looked intuitive to me. You flattened it out, and you would be able to tell the patient and the family, look, behind the scenes, this is really complicated, but your monthly burden, in a way like your monthly phone bill or the gas bill, the electric bill, is going to be largely predictable. And to me, that has policy-based or research-based as well as intuitive appeal.
Absolutely. And I think while the research that I talked about was around the Medicare population. If we think about this in the other insurance segments of the market, the high deductible health plans are on a major rise. We're only going to see more and more patients in high deductible health plans. And we're not just talking about the health exchanges or whatever happens with the ACA, but I'm talking about employer-sponsored insurance, where we are seeing a huge surge in the use of high deductible health plans. Think about what cost sharing will look like for patients in that. Pretty similar to the graphs that I showed you. Because until the patient hits, say, $4,000 in out-of-pocket spending and they meet their deductible, they're going to be liable for the cost for their drugs. So January, February, March of the month, when they're using such expensive medications like specialty drugs, you're going to see huge increases in cost sharing till they hit their annual out-of-pocket maximums.
Right.
The same thing with the increasing use of specialty tier co-insurance. So for the longest time, we've been seeing employers only using fixed dollar co-payments, even for specialty drugs. But in the last few years, we've been seeing an increase in the percentage of patients, employees, who are now exposed to a co-insurance as high as 30%.
Right. And when the Medicare program was designed, and when Blue Cross and Blue Shield were designed, 5%, 20% didn't sound like such a big deal. But now, because of the nature of the breakthroughs and other advances in pharma bio and the accompanying prices, that's real money now. And so, Kai, with regard to real money, you brought up one of my favorite topics in value, which was using cost per quality adjusted life year as a set of thresholds for defining value. And a question to you is that notion has been, in these United States, anathema, politically and even somewhat socially and culturally, because it sounds like the whole rationing thing again. And I know you're more of a researcher than a policy wonk, but I'm just wondering, what do you think is the acceptability of that notion of these thresholds, starting with the formularies and plans themselves, and then even to having to explain it to patients, if at all? Are we ready for cost per quality adjusted life year value thresholds and pricing drugs and access accordingly?
I think that's a great question. So, one of the things about the U.S. that gets knocked on a lot is that we have a fragmentary healthcare system, right? But one of the advantages on the flip side is that we have also, you can call it diversity of health plans, right? And so that allows for experimentation, such as the one undertaken by Primera. And you're right that, if you set a strict cost per quality threshold, in a sense of determining binary coverage, which is the traditional way in which cost effectiveness is used, for example, in the UK or Canada or so on, where above certain thresholds drugs are covered, generally speaking, then that might rub folks the wrong way. But I think neat thing about this particular implementation, which of course happened in Washington State with the value-based formulary, is they did not set a binary threshold, but a series of thresholds that were tied to co-payments, right? Such that even drugs which were, quote, on the average, for the average patient, not of high value, could be obtained and funded by the health plan, but just at a higher cost share.
So they're not off limits entirely.
Exactly, and so that provides a little bit of both incentive, which is what cost effectiveness analysis is attempting to do, but on the other hand also provides potential information signals to the patient with regards to the value of medications.
Aha, point well taken. So that gives me a little I'm more assured that this is not going to be a draconian thumbs up or thumbs down sort of issue. And I remember in the right-hand column of your Primera slide, you kind of laid out that sort of flexibility, which is welcomed.
Exactly. Yes.
So Mary, again, back to your organizations. I've done a little work in the hemophilia area, and I know that those people wonderfully and almost miraculously are kept alive anywhere from $250,000 to $1 million a year, especially those unfortunate people that were exposed to HIV and Hep C during, I guess, the 80s. And when they got their Hep C drugs a few years ago, there was a big bump there. But how accepting of your communities is going to be value-based purchasing and high-value healthcare as described?
So this is a really interesting space, and it's one where, listening to the presentations, we can see that there is going to be there's a tension between what is the largely healthy population, right? If we're looking at even hypertension drugs, right? So there was an asterisk that was their special needs cases, where we have a hard time with assessing value and outcomes with special needs cases. Well, as we heard this morning, there are also 1 in 5 people in Medicare is dually eligible, which means that there are a lot of special needs cases. And there are a lot of high-need patients, and there are a lot of people who rely on multiple expensive medications in order to maintain employment, maintain activities with their family, participate in the economy and their family and their lives. So where we're trying to be right now is to have a conversation around, I think that the bigger tension on the Hill is going to be around risk pools, something that we're very concerned about. But as we look at the value proposition, I think there is not one. If the one standard has to do more with the consumer as patient rather than the patient as a consumer, if you will. We're going to come up with different solutions depending on the lens through which we see most of this. And if you'll forgive me with those terminology, but we typically think about consumers as being folks who have a couple of, ear infections a year and that sort of thing. You go to the doctor once or twice a year. And then we also think about people who are patients who, many of us in this room are patients. We don't think of ourselves that way in our day-to-day lives. Patients to us typically means someone who has a multiple chronic condition or a functional limitation. I think that the outcomes conversation looks a lot different when the outcome that you're seeking is the ability to work, the ability to not go on SSDI, the ability to be able to maintain a life while living with a complicated health condition versus an outcome, which is the resolution of a stress.
Got it. And we're going to go to questions in just a moment. So if you've got one, I'll ask for them in just a second here. So, Veena, does this sound appealing to you? Coming back to that sort of crucible of patient-doctor decision-making, can they have a conversation about value? Can they have a conversation about incentivizing a decision to go for a high-value therapy as opposed to a lower-value one? Is that something that you would welcome? Is this sort of information that Kai can bring and Jalpa can bring insofar as the research base? Is that something that might inform that set of decisions?
Well, I think to some extent there are conversations about value that happen all the time. We maybe just don't appreciate them as being value conversations. For example, treatment in patients with advanced refractory cancers in which the benefit is possibly very low, the toxicity is high.
And my kid has to go to college, or my grandchild has to go to college, right?
Right. There is a lot of counseling around, maybe not so much specifically cost, the actual dollar amount, but is it worth it in a bigger sense?
So it does come up.
Yeah, and I think that that in terms of standard of care treatments, even initial therapy, there could be some room to discuss, drugs that may be similar in efficacy but different in cost to the patient and to the health system, and some room for physicians to take the lead in sort of counseling patients.
It's a good point, and I'm aware that I know that ASCO is working on sort of is it version 2.0 or 3.0 on their particular value framework that at least puts cost on the table vis-a-vis net health benefit. And then I know NCCN has its evidence blocks where they're trying to put it on the table. The cost parts of those are not yet terribly sophisticated. And the ASCO one is pretty much kind of what does the thing cost. And the NCCN is more on affordability, which is more of a nebulous term. So in any case, it's worth coming up. Questions? Ready?